Good evening, everyone. This is Dr. Fitzgerald, and this is our third class meeting of SPTH 5750 Seminar in Oral Rehabilitation. And tonight we'll be talking about auditory training and lip reading. Speech reading is the correct term, from our Nancy Ty Murray text, the third edition of Oral Rehabilitation, Children and Adults and Their Family Members. So we will begin tonight. I want to first thank everyone for their contributions to the discussion post on looking at an audiogram, thinking about what accessibility, the hearing loss that a particular client that you are serving, be that a child or be that an adult, actually has without amplification. And then some of you were able to secure from the audiologist an audiogram that also showed the aided responses. So you were able to comment both on what the client could perceive of different speech phonemes and environmental sounds without amplification, and then what they could perceive with amplification. We had a wide range of types and ages and disorders and different uses of amplification. Our clients ranged from a 1.5-year-old to a 96-year-old. So we had definitely across the age range. We had individuals with cochlear implants, individuals with hearing aids, individuals with BAHAs, and so we had a nice range, which should give us in this class, as we move along, the ability to talk about the wide variation that we see in persons with hearing loss. I do want to encourage you, and I want to commend Denise. She did a really nice job of actually putting her client's audiogram on the Count the Dots graphic. One of the things I really do want to encourage you as SLPs to do is actually to use those graphic tools, either the Familiar Sounds audiogram or the Count the Dots audiogram, and actually superimpose your client's audiogram onto those graphic tools. One, to help you understand what indeed they do hear, what is their auditory accessibility, how do they perceive sounds in their environment. So audibility is the name of the game. If you can't hear it, you can't understand it, and likely you can't reproduce it, and you can't monitor your own speech production. So it is important to be able to look at those graphs and to be able to talk about what your client actually does hear. And it's equally important, as we talked about last week, you are going to be the counselor, the interpreter of the audiogram, who is on site in your long-term care facility, your SNF, your hospital, your private practice, your school, your early intervention program. And there's not going to be an audiologist looking over your shoulder, whispering in your ear. So you are going to, as ASHA indicates to us as SLPs, you are going to be responsible for this information giving, this counseling, this education of both the client and significant others in that client's daily life. So it does behoove us as SLPs to get comfortable explaining the audiogram and to get comfortable explaining it to patients and their families, not with all the mumbo-jumbo and audiology terms, because if that's confusing to you, it's likely very confusing to the majority of the clients and their families that you're going to be working with. So learning how to put that auditory, audiological information in family-friendly, patient-friendly terms is really an important role that you serve. And oftentimes, as we know, graphics help. A picture is worth 1,000 words. So using the familiar sounds audiogram or that count the dots audiogram, where that 100 dots that are in the shape of the speech banana will give you a way to talk to a patient about what percentage of speech do you understand, what parts of this speech banana do you hear, which particular speech sounds do you hear. I always find that really helpful to me personally as a speech pathologist, because when I can explain that to the client, to the spouse of a client, to adult children of our geriatrics, to teachers, to the clients themselves, I can explain to them why in my speech and language goals I'm going to target these sounds. Why in my speech and language goal am I going to target those morphological structures that represent high-frequency phonemes in the word final position that are often softer than the running speech level. So plural S, past tense ED, ing, possessives, those morphological structures that I'm going to be targeting in language are being targeted because the person with a hearing loss likely doesn't hear them. The reason I'm going to be targeting in my speech reading or my auditory training the differences in that place feature. Is it alveolar? Is it velar? Is because that's the hardest acoustic feature for people with hearing loss to determine. So one of the reasons it's important for us as SLPs to be able to explain these audiograms, to be able to explain audibility, to be able to explain how that relates to speech perception, is it gives us one more way to have our patients and their families understand, why am I working so hard on these same speech sounds over and over again? Why does my child have these goals year after year to work on morphological structures? Why do we spend so much time in our communications training for our senior citizens working on being able to tell the difference in some of these contrasts among these visees? So again, it provides you with a way to explain, to provide the rationale for your speech and language treatment goals. So that's one of the reasons for getting good at this explanation. But the other reason is to actually write an auditory training goal, to write a goal for speech reading. Oh, Erin, that's a super question. Thank you for asking about that question. The way I explain it is that, in fact, typical listeners have 2 ears, and there's a good reason for 2 ears. Speech perception is significantly improved with binaural hearing. When you have just 1 ear, atresia, or a severe hearing loss, and essentially you have what is sometimes called single-sided deafness. You think, you remember I told you the story as a young audiologist. I grew up being trained by outstanding audiological professors, but the thinking at one time was we can do okay, mostly, with 1 ear. So when we saw patients with atrasias, when we saw patients with single-sided deafness, unilateral hearing loss, we would generally say, well, you need to take good care of your good ear because you've only got 1 that's really going to do the work. But you'll be fine. And that was a lie. We have done lots and lots of research, both with children and adults, and we now understand that single-sided deafness, normal hearing in 1 ear, and a severe, profound loss in the other ear is a significant detriment to speech sound perception because you don't get the benefit of 2 ears. 2 ears makes the sound louder, so soft sounds are hard. 2 ears enables you to tell which direction sounds come from, and so you automatically turn and localize and look for the source of the sound. In noise, which unfortunately is where mostly we listen, in schools, in social settings, we are listening in noise. And 2 ears enables you, again, to discriminate, to tell the difference in speech sound in that background of noise. So you do need to spend a lot of time talking with clients about speech perception is much more difficult for a person with a unilateral hearing loss than it is for a normal listener, particularly in difficult or adverse situations where there's noise in the background, where the speech is soft, where the speech is coming from the poor side, where there's not enough light in the room or not a clear visual path, so the individual can't use auditory visual integration. So that's sort of the way I come at it. If it's a child, I do share the research that has been done, again, in multiple different studies, saying that children with single-sided deafness who are not amplified or don't have the advantage of some type of amplification system very often struggle in school. In fact, as many as 1/3 of that population of individuals with single-sided deafness may repeat a grade or require other special education and related services support. So it's not fine. When I used to tell those patients, you'll be fine, I simply was quoting what I had learned in class, but it wasn't true. And audiologists have now recognized the fact that that is not a true statement, and that we need to amplify, we need to provide assistive listening devices. All right, Jill, that's exactly what you need to be talking about to your client. You need to make sure that the family understands that, because sometimes families say, well, he does fine at home. I don't see him having any problems. And that may be one, in that home setting, he's conversing with very familiar people. He can oftentimes get closer if he needs to, or tune out if he doesn't want to hear Mom give him a direction about picking up his room. And families oftentimes don't appreciate how difficult a classroom is, how hard it is to learn to read in a noisy classroom. They don't appreciate sometimes how difficult peer social interactions may be in noisy settings where kids get together. And so families sometimes discount the problem. Well, I don't want him to have to fool with that hearing aid or that Baha. You know, it'll make him seem different. So families oftentimes have a lot of reasons that they don't want to confront the underlying problem or the potential problem that a child might have. Teachers go, well, one ear's okay. And so our job as SOPs is to provide factual information based on research and evidence-based practice about what really are the consequences of unilateral hearing losses. Other questions that someone wants to address. I was excited to see that several of you have adults who are new CI users, and that really speaks to one of the things that we're getting ready to talk about here in terms of auditory training. And that the adult population, whom we typically see for formal auditory training, once they have been implanted with a CI, is this new CI user. So some of you are going to find that information right on point for your case studies. I do want to let you know I am aware of your comps scheduled for July 1. I put up in eLearn just a PDF of a little study guide that I have made over the last several years for both distance ed students and for residential students who are taking the TSU comprehensive exams. Dr. Smith and Dr. Gibson decide what questions they want to ask based on questions that have been submitted by faculty members over the years. So I don't have any input into what might be on the comps this time around. I have frequently said to Dr. Smith and to other members of the faculty, remember, students are taking oral rehabilitation during this last semester. So they have not completed the course. So the questions that are asked have to be on information that we cover in the first several weeks. And those were the kinds of questions that I submitted. The advantage is this is the last course that you need to study for because you've just been in the midst of it. You've done these chapter questions, which you all didn't want to do and thought were a waste of time, but you've gotten some information that will serve you well both on the comps and on your midterm by doing that. And you have this information should be fresh for you. So certainly AR is not the primary thing you ought to study. We've talked a lot already about CORE and CARE as sort of easy acronyms just to help you remember if I were to encounter a case study where hearing loss was part of the picture. I would want to remember CORE is how I assess a client of any age with a hearing loss. I look at their communicative status, not just the audiometry, but these self-reports that they give me, the history that they give me, the interview information that I get from significant others. I'm going to look at their overall participation variables, the O. I'm going to be thinking about hearing loss is influenced by social, emotional, psychological, educational, and vocational characteristics of my patient. I'm going to be thinking about R, related personal factors, personality, IQ, cultural and linguistic diversity, attitude or motivation for participating in a therapy program. And I'm going to look at E, environmental factors. I'm going to be thinking about what are the barriers that this individual will face? What are the acoustic conditions that this individual faces every day? And what are the services that this person has access to? We've talked a lot already about AR is the poster child for interprofessional practice. Our AR service delivery teams are, in fact, interprofessional practice, hopefully at its best. But it is a team approach. It's a coordinated approach. And then when you have to design a treatment plan for a person with a hearing loss, child or adult, you use the CARE, C-A-R-E acronym. The first thing you do attend to is counseling and psychosocial issues, including modifying a person's attitude or motivation. So you spend a lot of time providing information. We just talked about that. What does this hearing loss mean? What is the audibility of the speech signal that this child is trying to learn or this adult is trying to manage? So we spend a lot of time providing information, a lot of time in counseling and guidance, and we're going to spend all next week actually sort of talking about those things. The A in the CARE model is this idea of audibility and impairment. So what kinds of devices what kind of technology does this individual have access to? Hearing aids, cochlear implants, BAHAs, assistive devices, hearing assistive technologies. Then the R from CARE, C-A-R, is remediate communication activity. So this is where you look at your patients. You've already assessed their communication status, so you know what they hear, how well they lip read, what their speech is like, what their language is like, and now you're going to do remediation. You're going to do therapy. You're going to design a plan, and you're going to begin with things like auditory training, speech reading. If it's a person, a child in particular, you're certainly going to address speech and language and literacy goals. No matter what the age of your client, part of remediating these communication activities is working on communication repair strategies, communication tactics, which we will talk about extensively next week. All people with hearing loss need to learn how to manage their environments. They need to learn what they can do and what their partners can do to help the communication situation. They need to learn to be assertive in asking for what they need, but not aggressive and not withdrawn or passive. And so you're going to talk about those and make that part of your treatment plan. And then the last element of care, the treatment approach, is like the last element of the assessment approach. It's about the environment. Because one of the things that we have to figure out with all of our patients with hearing loss is how can we improve their listening environments. So we have to think, what can we do to improve the acoustics of wherever they live and work and play. We need to think about how we can train significant others, because this is the one area of therapy where I would postulate to you that the person with a hearing loss is only part of the equation, only one target. You're also going to target those significant others: parents, teachers, co-workers, medical staff if they are in residential placements, family members if they are adults. You're going to train them to use some tactics that help the person with a hearing loss communicate, even when the listening conditions are adverse or hostile. So a target of therapy is significant others. It is the partner of the individual with a hearing loss. So I assure you that for your comprehensive exam, the last 20 minutes, plus taking a quick look at the chapter questions would be all you would need to know to do well. So don't spend too much time on AR as you study for your comps. I think you'll do well. Next week I will review, and I did put up as an attachment to the news announcements, the midterm study guide. The midterm exam is online. It is not proctored. Just don't share that broadly. It would really help me if I don't get overruled. So it would be good not to brag about the fact that this one is not proctored. I appreciate that you're willing to help me. I'm willing to help you. You're willing to help me. It's after comps, after the 4th of July. It's open for 3-4 days. You should study, and then you can take this. Every time that I have given you feedback in the Dropbox on your chapter questions, I've said, out of this chapter, pay a special attention to, as you study for your praxis, your comps, and your exams. I would take a look at that because I literally wrote those as I wrote questions for the exam. I also gave you a study guide. It will, and we'll go over it more next week, it will have questions that are multiple choice, fill in the blank, matching type definitions, similar to the end of the chapter questions from your timeline text. And then it will have several short essays with words like describe, explain, compare and contrast on service delivery, auditory training and speech reading, informational counseling, interpretation of the audiogram, and functional checks, troubleshooting of amplification devices. All of those have been material that we've already covered. So I'll talk to you more about it. But again, you probably are ready to take it right now and would do well. Again, it is a 2-hour exam unless you have accommodations and modifications, and then I have a special release that will allow extended time if I have a letter from the Office of Student Disabilities. So let me put your mind to rest about comps. I cannot give you any more information about comps. Dr. Smith and Dr. Gibson are the people who determine which questions from a pool submitted by faculty members, which ones they're going to use this time. So, and what their format is and what their timing is. So I'm sure they will provide you with good guidance and direction about how they are going to choose to handle the comps this time around. Take a deep breath. Questions that I can answer. And let me remind you that next week we are going to move on to part 3 of our textbook. We're going to be looking at communication strategies, communication fluency, communication difficulties, how do we assess that area, and then how do we treat that area, and how do we provide appropriate counseling, informational counseling, and this sort of personal adjustment counseling, reasonable expectations counseling. Okay, take a deep breath. We are going to be talking about auditory training. We are in chapter 4 in your textbook, and this is where we're going to, in fact, use the information that we've been working on in terms of what does this audibility issue really mean. So we're going to be thinking about what does audibility mean as we think about auditory training. This PowerPoint, Whitney, as I said, is attached to the news announcements. It is a very slight modification of the PowerPoint that has been posted in the content section of eLearn since the beginning of the course and in the news announcements since last week. I made a slight change in about 4 slides, but it is the last or next to last PowerPoint, the next to last attachment to the news announcement for tonight. And the same thing actually is true of the speech reading one that I'm getting ready to do. Over the weekend, I looked them over and made a very few changes. If you've got the other ones already downloaded and are taking notes or watching them, you're going to be fine. I didn't make that many changes. I changed the color of one of them because it's much easier here in Collaborate if we don't have quite so many things going on. Lots of color makes it hard for you to download them and print them. You use up all your color printers, and sometimes it doesn't show up here in Collaborate as pretty as it actually is. Let's think about our goal with auditory training. The goal is to help our patients, again, from birth to death, improve their ability to recognize speech using the auditory signal, and then to meaningfully interpret that auditory experience. And particularly, because we are speech-language pathologists, it is the speech signal that we want to focus on. Now, it's also true that it's nice if our patients can hear birds singing and leaves rustling and water pouring and a babbling brook. And I don't mean to denigrate the importance of a rich auditory environment, but the truth is what's important in terms of quality of life, mostly, and engaging with other people is to understand their speech. And obviously for us as SOPs, that is our professional focus. So our goal always with auditory training is to teach our clients to use the residual hearing they have with the best amplification that our co-professional audiology colleagues can provide, because we're trying to maximize their communication. So first and foremost, it is critical that they be fit appropriately, and that we do our part in encouraging patients and their significant others to make the choice to see an audiologist, look at the range of options for devices that might be helpful to them, and make the best decision about the device that is most appropriate for their particular hearing loss. It's also really important that we remember that auditory training is not going to change the person's hearing sensitivity. It is not going to make them hear better. Now, sometimes we use those words in the broadest sense. We're going to help you listen more carefully. We're going to improve your listening skills. And that part is true. But you are not going to grow new hair cells. You are not going to change the ossicles in the middle ear. You are not going to add more neurons in the auditory cortex. So you have to be really careful in how you use language to help the patient and the family understand what auditory training is about. It is going to enhance the person's ability to use what sound is available to them. So that's why auditory accessibility through the best possible fit is important. Most auditory training is provided for children who have prelingual hearing loss, meaning before the onset of speech and language, or paralingual hearing loss. Hearing loss occurred as they were beginning to develop speech and language, or postlingual hearing loss, after they developed basic communication skills, but before perhaps they had developed adult-like speech and language. Your discussion question for next week, based on this chapter, is to look at the two little boys that are presented at the end of chapter 4. Both of these children have had meningitis. One child had meningitis shortly after his 3rd birthday, and then had another even more severe drop and lost his hearing almost entirely at age 7 and received a cochlear implant. Both of these children are cochlear implant children. The next little boy actually lost his hearing when he was 5 months of age. So he had a few months, presumably as a normal hearer, but then had spinal meningitis. He received a cochlear implant and interim therapy. The results, which you're going to read in your textbook on page 172, 173, and 174, are different. And the reason I chose this as a discussion question for you was to help you recognize that outcomes are often different. So the age at which the hearing loss occurred, the severity of the hearing loss, the success, both of them have CIs. Some individuals are stars and some are slow going, even with a cochlear implant. You may pick one of these children to talk about, to discuss, and I've listed some questions for you to talk about. But pick either one. They are both in auditory training programs. So you're going to get a chance to look at the goals that are set and to look at their progress and outcomes and think about these two little boys, Drew and Bobby, who present very different challenges for you as the SOP in charge of their auditory training intervention. So I want you just to use that as a way to sort of get a handle on what does auditory training look like with two young CI users. Bobby represents a child, because he had meningitis at 5 months, who have little or no memory of how speech sounds sound. Now, he did hear for a few months, and that is invaluable experience for his growing, developing auditory centers in his brain. And he knew at some level, as a neonate and a young infant, how to attend to the auditory speech signal. He had made some association with sound, speech sounds, the face, and auditory signals. Drew, on the other hand, had a much longer period of hearing. So he had normal hearing until his 3rd birthday, when he too contracted meningitis. So he had developed, we presume, normal 3-year-old speech and language skills. So that is a huge difference. He now has vocabulary, simple sentence structures, basic early developing phonemes, understands that the speech signal carries meaning. He also had some hearing even after he contracted meningitis. He has a moderate sensorineural hearing loss in his right ear and a severe hearing loss in his left ear. He immediately got binaural hearing aids, was in an early intervention program, a preschool program for children with hearing impairments with what we presume was very good speech, language, listening support. And then at age 7, he lost his hearing significantly and received cochlear implants. So again, the candidacy for auditory training can be wide-ranging. For adults, we often see that they will be fitted with cochlear implants or with hearing aids following a severe, sudden hearing loss. And it's those are the adults who typically are candidates for auditory training. We also see that we often work with clients who have what we call dual sensory impairments. That means hearing loss and vision impairments. So an individual who is facing both loss of vision and loss of hearing may well be a candidate. I put an article from an ASHA online course up in the news announcements by Sanders called Dual Sensory Impairments. And those of you who are working with adults in skilled nursing facilities where there are visual issues as well as hearing issues may want to take a quick look at that. It's an excellent review of vision impairments. And if you're not familiar with the kinds of vision impairments that are characteristic of some of our geriatric population, that might give you a quick kind of primer on visual impairments that we see particularly in our geriatric population. And I know several of you have got case studies where it's not just about a hearing loss, it's also about some visual issues as well. What we see is that individuals with hearing loss who are fitted with cochlear implants tend to be the pediatric clients and the adult clients who are on our caseloads, our therapy caseloads, for specific auditory training. Typically with adults, it's short-term, and we're going to talk about some of the options for online computer-based training for individuals who can't get to therapy or where therapy for adults doesn't seem an option. We oftentimes see school-based SLPs who are asked to pick up newly implanted youngsters. For example, a child like Drew, who gets a cochlear implant at age 7 or 9 because of either a drop in hearing or some change. And the SLP is typically the one who carries out the auditory training. The individual may get some very initial orientation to the CI from the audiologist at a large university-based cochlear implant center just as the cochlear implant is being mapped. But because those surgeries are typically done by a physician associated with often a university program or a large cochlear implant center, that's where the initial therapy is done. But those individuals go back home. They go back to their local school, they go back to their local community, and it is the local SLP who then must pick up and continue the auditory training services either in the schools or in a therapy setting for an adult. So again, those are kind of the candidates. When we think about auditory training, as Nancy Ty Murray in your text, Chapter 4, talks about, it really is pretty simple. Beginning on page 142, Nancy Ty Murray talks to you about how do you design an auditory training program? How do you write therapy objectives? What are the kinds of skill levels and stimulus units and activities that you design for a client, and how do you make it more difficult? And it really is these four things. So you as an SLP have control over these. If you look at auditory skill level, you have to determine what is the person's auditory skill level. What's their use of the hearing that they have left with their amplification device. So that's why you spent all this time last week looking at audiograms, thinking about what do they hear, particularly what do they hear with their typical amplification device, a hearing aid, a Baha, a CI, with an FM in their listening situation. And you are trying to think about this in terms of a continuum. Back in the 1980s, Erber developed sort of a 4-level skill model. It's the picture that I'm getting ready to show you. It's in your textbook. It's on page 144. This is important because this is kind of the hallmark of auditory training. Where am I going to be working first? And auditory training is a continuum, and we are trying to increase our patient's skill at each of these levels. So we are looking at this idea of sound awareness. So can the individual hear sound? Does a baby hear the doorbell, the microwave bell, the sound of a loud tricycle or motor toy that a brother is playing with? Does the adult hear the doorbell, the significant sounds in their environment? That's simply awareness. That's hearing it, localizing it. Sound discrimination is the next level. It is a gross, are these two sounds the same or different? Can I tell that something was a different sound? Comprehension, identification is really the next level. And identification is, do I know what that is? Can I put a name to it? Identification is a basic auditory skill where the listener can label some auditory event. That's the drum, that's the doorbell, that's mom's voice, that's the sound of a pig, that's the sound of a car. And comprehension is that higher level auditory skill in which the listener is able to understand the meaning of the message. So it's what we think about as comprehension. You do want to be thinking about games or activities that might be appropriate at each stage of auditory skill development. So you want to pay particular attention in your textbook to page 144 and 145, figures 4-5. 3 and the table 4-2. They're a nice little summary of this information. Now, you as an SLP could, from what we've just talked about, you could design an ever-increasingly difficult set of activities for your client, child, or adult across these levels. Obviously, we don't want to stay at sound awareness any more than just to call attention to the sound. We do it with infants, with very young preschoolers. We ask adults in the first week that their CI is activated. What did you hear this week that was new for you? Was it the water running? Was it leaves rustling? But because our focus is on speech and language, we want to move to speech and language and higher level auditory skills as soon as possible. So I always say this to my students: I will come back to haunt you if I ever hear that you as an SLP are working with a child or an adult for months and months and months on sound awareness. Can you hear the knock at the door? Can you hear the drum or the bell? That's not a functional goal. Again, might be appropriate in that first week or month. But after that, you need to be moving on to sound discrimination, sound identification, comprehension of speech and language. Because that's, again, what we're focused on and what the purpose of these devices is. The next element in designing an auditory training program looks at what kind of stimuli you're using to train. Are you going to train analytic, discrete stimuli, where you are actually focused on the segments of the speech signal, the syllables, the phonemes, the distinctive features of the sound? Is this a nasal sound? Is it a fricative sound? Is this a voice sound? Is it a voiceless sound? So that kind of discrete, analytic type of activity. Or are you going to focus on what is called synthetic training, when the stimuli that you're using is about words, phrases, sentences, so that you are looking at a broader, more holistic approach. Synthetic training emphasizes the understanding the meaning, not necessarily the identification of every single sound in the word, or even every word in a sentence. Now, we need to think about this continuum as, in fact, a continuum. It's not either or. It's what mix of activities I, as a therapist, choose to use with my client. So you want to be thinking about it as a continuum, as Nancy Ty Murray says on page 147. The third design principle relates to the type of activities that you're going to choose to do with your client. Again, adult or child. You can do formal, highly structured, drill kinds of activities, scheduled at a specific therapy time that your client comes to see you for auditory training therapy. Or you may use an approach that is more informal, where auditory training activities are embedded in daily routines or in other activities. We oftentimes choose that for young children, and we train parents to call attention to sound, to help their children discriminate sound, to identify sound, to comprehend sound in the context of everyday activities. We do that with adults, where we get adults to tell us what are the kinds of activities that you engage in at home with your family, in a work setting, in a recreational setting, or a social setting. We also may combine the two. Again, think about this as a continuum. We might do some of both formal, highly structured activities as well as informal activities. The fourth element of designing any auditory training program, setting up objectives, is to think about the level of difficulty. Auditory training is something where we do want to start easy and build toward more difficulty. We want to start our clients, particularly our new users of amplification of any kind, with success. We want them to get benefit from their devices, feel confident that their devices are in fact helping them. So we do want to start our training at a level where they can achieve some success, and then quickly, if we can, move them to more difficult levels. And there's some ways that we can make the task more difficult. This ought to make sense to all of us as SLPs, because it's how you make any linguistic task or cognitive task more easier for your client. You want to look on page 149 in your text at figure 4-5 that simply reminds you that there are lots of ways to make things harder. Closed set versus open set versus limited set. If you ask me anything and I have only 2 items to choose from, that's a closed set. That's easier. If it's an open set and you just ask me a question with no choices or with a large number of choices, that's harder. If you look at the stimulus unit, are you going to use words? Or are you going to use complete sentences? How similar are the stimuli? If I'm asking you to tell, are these two the same or different, and they are very close to each other acoustically, that's harder than if they are very different. That's why these hierarchies make a difference. If I ask you to tell me, are these the same or different? That's easy. That's a consonant versus a vowel. It's a long duration sound versus a staccato sound. Those are very different acoustically. That makes it easier. If I ask you to tell me the difference in that's harder. Those are both consonants. They are both stops. They differ only, they're both voiceless. They differ only by place of articulation. So that is really hard. Tack, cat. That's really hard. So again, you as an SLP don't need me to tell you about that. You can simply look at acoustic features, distinctive features, and make up your own list. Another way to make sounds auditory stimuli and training vary in difficulty is the context. If you have contextual clues, situational clues, or linguistic clues, then the speech stimulus is easier to gain meaning from. If I point and gesture over to the ball on the floor with an 18-month-old, and there's nothing else on the floor but the ball, I say, "Get me the ball," and I point. "Get me the ball." The child may well pick up the ball because there's situational clues. They may not understand anything I said. Now, we do start there, but again, thinking about what makes it easy or hard. If I tell an adult in our speech reading class today, we're going to be talking about cars. We're going to be talking about antique cars. Let's look at these pictures I brought here. And you put out a series of antique car pictures. Then you say to the patient, "Find me the red car." The patient has so much more linguistic context, situational context, a picture clue. That makes it easy. You gradually withdraw that contextual support, and it's much harder. You want to look at the type of task. Can you make the task spontaneous or structured? If the task is very structured, then that is an easier task than something that's very unstructured. The last thing that is critical for us to think about as SLPs is to think about the signal-to-noise ratio. We can alter the listening environment and make it more difficult for our client by increasing the background noise. That makes the listening task harder, but it also approximates the situation that the patient is likely to find themselves in. We might begin by using background noise that's soft, instrumental music. We might then use a low background speech babble, like a talk radio show. Then we might use background noise where there is a voice reading an interesting story that makes sense. That's that divided attention. And so we often design auditory training tasks where we increase this signal-to-noise ratio, that background music, that talk or babble, and then actually interesting speech stimulus about a story or something that's very attention-getting, and still asking the individual to discriminate the stimuli that we're presenting. So those ways of making sounds easier or harder. Here's just a little difficulty level synopsis. Easier versus harder. So when you write a goal and objectives, one of the things is you may be at the same level, you may still just be doing speech discrimination, same or different. Or you may be doing identification, what is this sound? But you could make it harder by making it moving from a closed set to an open set, and that could be an objective. Moving from words to sentences, that could be another objective. Moving from dissimilar stimuli to similar stimuli. So with each of these level of difficulties, you've got another objective under a larger goal. You always want to make sure that it's challenging to the client, but not frustrating. The general rule of thumb, and it's only a rule of thumb, is that when the individual can achieve 80% accuracy, it's time to move on. When the individual is still struggling and is less than 50% correct, you're too high. It's too difficult. So you want to be working in that sweet spot. Now, obviously, our patients differ in their tolerance for frustration. They differ in their persistence at a task. So again, it's always an individual decision, but you want to be thinking about that. One of the things that we know from a lot of research, basic neuroscience research, as well as self-report and a variety of other tasks, is listening is hard. Listening is especially hard for individuals with hearing loss. And I think those of us who have normal hearing often underestimate the level of stress and anxiety. In fact, there's a lot of research looking at stress levels, looking at basic physiological stress levels of individuals with hearing loss who are in difficult listening situations compared to normal hearers in difficult listening situations. So it is very real. Again, there is both self-report anecdotal literature, there is basic physiological data in terms of stress, there are task differential performances, there's this fatigue factor. We hear this over and over again from individuals with hearing loss. I'm exhausted when I've worked a whole day trying to listen to my clients. Students will tell you, I am exhausted after going and listening to an auditory lecture. When the patient has good enough language skills and is self-aware enough, as are middle schoolers, adolescents, adults, to tell you about their stress level, that's a help. But we have to be clear that those same levels of stress probably are experienced by our clients who are not as able to express that frustration, by our younger children. So we have to be thinking about making adaptations for this issue of fatigue and stress when the situation is difficult. And that means even in our therapy, we're doing auditory training for 10 minutes, 15 minutes, and take a break, 10 minutes, 15 minutes, take a break. Sometimes it needs to be 5 to 10 minutes and take a break. Again, we need to be very sensitive to when we are challenging our patients, but not frustrating them. So this guy named Norm Erber, back in the 80s, developed this idea of this 4-level hierarchy. And we need to be thinking about, again, we're moving up this hierarchy. We are moving from easy to difficult. The first thing you need to do in developing an auditory training program is come up with objectives. So literally you need to write a treatment plan, write objectives. And you have to consider which sequence the person might best acquire, and then you advance them. If the client has only a few auditory skills, you may begin with sound awareness to teach them that sound has meaning. So you play the door knock game with a young child. You go, ooh, I hear that. And you point to your ears. I hear that. That's the door. And you walk the child, carry the infant over to the door. Ooh, look, who's there? And open the door, and it's mom, or it's their dog, or it's their favorite teddy bear. obviously a very simple activity, but sometimes for young children in particular, that building the idea that they're aware of sound and sound has meaning, and I do some action when I hear something is really important. You do that again initially. Once they are aware of sound and that sound has meaning, then you build gross discrimination. Is it loud? Is it soft? Is it long? Watch. Let's make our car go. Ooh. It stopped. And you stop the train, the car, the dog, the person that's walking. Ooh. It stopped again. So you essentially play musical chairs with showing rate and duration. Again, once you've mastered some of those very basic things with young children, then you move on and you've got a better sense of how well does this child attend, how quickly are they picking up these games, and you begin to make some decisions about is this going to be an analytic or is this going to be a synthetic kind of training? When you think about actually doing analytic training, we're in your textbook on page 150 and following. You begin with the part of speech that is loudest and longest. Do you remember in phonetics we talked about vowels being different than consonants across all the languages of the world, and that vowels are the core or the nucleus of the syllable, that they are louder and longer. They carry more energy in the speech stream. So we do begin with vowels for our first objectives. And within the vowels, we have to pay real attention to which vowels are most different one from the other. So Dr. Matlock's speech science ought to be coming to the fore, and you ought to be thinking about formants and spectrograms, and you ought to remember what you learned in phonetics. Vowel formants are the resonances in the vocal tract that cause some frequencies to have more energy than others. And it's typically the first, second, and third formants of the vowels that distinguish one vowel from the other. And I bet you thought you would never have to look at this again. But here's where it comes in handy. These are vowels. Everybody got that? They look like vowel phonemes to me. And we're looking at first formants and second formants. First formants are those lower frequency formants, and second formants and third formants are higher frequencies. Now you're going, oh yeah, I remember that. There was something about is that low open back sound. E is that highest front sound. Oo is that highest back sound. And we're thinking about the patterns of these formant frequencies help us as listeners determine which vowel sound was it that we heard. If you'll look in your text on page 152, you'll see a table that is going to help you recall some of those differences. The vowels, the first formant and the second formant. The reason that becomes really important is if we think about individuals with hearing loss, we have many individuals with hearing loss, unfortunately, who have little or no residual hearing up above 1,000. They may have better low-frequency hearing, so they can hear that first formant, but they don't hear the second formant because of damage to their cochlea. So they don't hear the second formant. And if you cover up the last column on table 4.4 on page 152, you get rid of the second and third formants. Look over here. Oo, E. The first formant of E is somewhere about 270. The first formant of Oo is somewhere about 300 hertz or cycles per second. That's almost the same. So for a deaf child who doesn't have any residual hearing above about 1,000, E and Oo sound alike because there's nothing up there at the second and third formants. Does that make sense? So for a deaf child to say, can you tell me the difference between B and boo, and those are your two stimuli, that child is never going to get it. They're going to be at 50% or less correct because they don't know, because they can't hear it. But if you say B, ba, they go, whoop, I got that one. I can get that one. B, ba. I can make that distinction. So it's absolutely incumbent on us as SOPs when we design auditory training hierarchies or materials to be used in these analytic structured training activities to make certain that we are giving the client a possible task, a task they can be successful with, and that we understand first and second formant information. So if you'll look in your textbook on page 152, where we were looking at that table that told us first and second formants, but look at the bottom of 152 and to 153, there are a whole series of objectives for vowel training, auditory training, and sample objectives that you can use. Now, wasn't Nancy Tomori nice? She provided you those. I'm going to show you some commercially available programs that also do your work for you. But I guess I'm here tonight maybe to convince you that you're an SOP, you're taking Dr. Matlock's speech science, you've had this course, you have had an excellent course in phonology and articulation. You could figure it out on your own because you understand the underlying principle of discriminating formants for vowels. You're going, that's too hard. I'd have to go look it up in the book. That's fine. Go look it up in the book. That's a good thing to do. Or purchase one of these commercial programs that does it for you, that gives you stimuli, picture cards, that will help you do that so that you don't have to actually work through every single set of stimuli. So again, vowel training begins with awareness, and then you build to contrast that where the vowels differ in the first formant, like meat and mat, and then where the client does have to discriminate vowels based on the second formant, if, like B and boo, if you and the audiologist are convinced that there's enough hearing at the second formant for that to be a possibility. And you play these minimal pairs games. Which one did I say? When we think about consonant auditory training objectives, we're moving to a little bit harder level. Consonants are harder than vowels, but we're going to be using that same information that we learn in phonetics, in phonology, and artic, in speech science, and we're going to think about what we as SLPs know about features of articulation. How many of you remember the place, manner, and voicing chart? I want to see a show of hands. Who remembers place, manner, and voicing? Remember how much you hated it? Some of you who had me went, do we really have to learn this? Right. Ashley, you're right. You knew it from my phone because I made you learn it. The reason that's important is now it took you 3 years to finally get to the class where it is important, right? Okay, the extra credit saved Ashley, but now here's the reason it was important. It is basic artic. When you think about people with hearing loss, the easiest feature for people with hearing loss to distinguish is voicing. Remember that thing called the voicing bar that was way down there on the bottom of the sound spectrograph? It's that lowest sound. Voiced versus unvoiced is the easiest. Manner is the next easiest, whether a consonant is a fricative or a nasal, because the nasal consonants have that 300 hertz nasal murmur. So if you put in contrast to any other consonant, even a person with a very profound hearing loss, again, low frequency hearing only, that ski slope, precipitous sloping loss, can hear that. By far, the most difficult feature to hear are those that relate to place, because those place cues are conveyed with mid to high frequency information. Now, we're not going to redo phonetics, but if you will look in your textbook on 155, table 4.-7, 4-8, 4-9, again, gives you the hierarchies that you can use for analytic auditory training of consonants and samples of objectives where you're starting with easy nasal versus non-nasals that are also differ in place, to nasals versus non-nasals that are voiced that don't differ, to discriminating unvoiced fricatives versus unvoiced stops that differ in place of production. So again, you could design these, I'm absolutely convinced, but you'd be sitting there looking at your picture card stimuli or your object stimuli for young children, and you'd be spending a lot of time. Again, at the end of this PowerPoint, I'm going to show you some commercially available programs that have sort of put these together that are inexpensive. I mean, one of the things that we have to think about, I think, as SLPs is we will see individuals with hearing loss in our practices, but we won't see the majority of our population won't be hearing loss. So we'll see them occasionally. And if it's not something where you're playing with these kinds of activities every single day with several clients, designing these hierarchies does mean I have to go back to the book and look. Or I need a commercial program that gives me the right word list so I can design these activities. The other thing that we want to think about is synthetic activities. Many of you have said to me you are interested in early intervention, or you are interested in working with adults, either adults in residential settings or adults in a private practice. And when we think about those types of clients, sometimes it makes more sense to think about developing synthetic training objectives, thinking about something that's more holistic. And if you look in your text on page 159, Nancy Tamori begins to talk about this idea of synthetic auditory training, looking at ways to make this auditory training embedded in daily activities, embedded in functional communication. Typically, when we do synthetic training objectives, we might begin with simple discrimination activities that involve the suprasegmental aspects of speech: prosody, intonation, stress, duration, loudness. So we might be simply asking the client to distinguish multi-word utterances from a single-word utterance. I see the big black cat. Dog. That's multi-word versus single word. Discriminating one-syllable word from two-syllable word. Show me toothbrush. Show me cat. Again, one syllable versus two syllables. We, again, oftentimes begin with little children with something like, uh-oh, oh, as we fly a toy plane around the sky. Uh-oh, as we drop a block. Those two auditory stimuli are very, very different. They differ in intonation, they differ in duration. So we start with those kinds of things. The other thing that we want to think about, particularly with adults, is that we want to be thinking about ways that we can be training something that is meaningful for them. So we may organize our speech reading training and our auditory training and our communication skills training all around a theme. So with our seniors in a skilled nursing facility, we might do short-term group therapy, and we might do it around themes. We might, I know Mrs. Herbert oftentimes goes to one of our assisted living centers, and she will do a men's group and a women's group, just because the residents feel more comfortable in that. In the men's group, they're talking about sports, they're talking about cars. In the women's group, they're talking about gardening and cooking. Now, I realize that that is very gender specific and may not be appropriate, but we are talking about older adults who are comfortable in some of those more defined gender roles. The idea being that we're talking about something that's interesting for them. And so our speech reading goals, our auditory training goals, our practicing communication strategies are all embedded in a topic or theme that's appealing to our participants. We do that in school. In fact, there have been a lot of suggestions that in school, one of the unfortunate things that sometimes happens is that we send children with hearing loss to the speech pathologist to work on auditory training. And so the speech pathologist may see the client and work on 15 minutes of auditory training, 15 minutes of vocabulary training, 15 minutes of language therapy, whatever that is, and 15 minutes of speech therapy, whatever that is. And there's a lot of thinking now that little, let me break it up, let me make it structured, let me just do all the things I'm supposed to do with you, auditory training, speech reading, vocabulary building, language, and I'll hit all of my objectives in my therapy time with you. That really is not in the best interest of students. We listen, we look, we use communication strategies, we try to comprehend meaning all at the same time. So maybe we should be doing less of this structured, formal, isolated kind of intervention and more of an integrated, embedded type of holistic intervention where we take what is the reading story for the week, what is the science lesson for the week, and put all of our auditory training, our speech training, our language training into a context for the youngster that they can then take back into the classroom situation. So I just offer that thought that we might need to be thinking and asking ourselves, given the age of our client, given what skills seem to be a priority, if maybe rather than these little isolated, oh, I did auditory training today, I did 10 minutes of it, that might not be in the best interest of our clients. Sometimes, and there are programs that do suggest that 10 to 15 minutes a day devoted to formal auditory training. But then we have to think about how to put those formal objectives into the rest of the day, into a context for a child. So we have to think about at home, at school, just as we have to think about for our seniors in a long-term care setting. Is there a way to integrate what we are doing into a more meaningful, functional communication activity? Nancy Tamari, this is one of her pet peeves. I've heard her talk about this many a time, that we as SLPs get so hung up on our reinforcers that we choose reinforcers that take forever. A reinforcer is supposed to be increasing the frequency of a behavior that we are targeting. And we need to be thinking about what can we do that's quick and that keeps the focus on the skill or the activity. So we have to have it varied, it has to be quick, we have to think about building children's tolerance for I produce a whole lot of responses and then I get a reinforcer. In other words, that one-to-one reinforcement schedule we may use very, very early in therapy with individuals who have not had any formal experiences in therapy, but we certainly want to wean our clients away from one-to-one reinforcement schedules. So we want to be looking at managing our reinforcement. I told you I would provide you with some suggestions. Here are some commercially available programs or programs are available through nonprofits that do the hard work for you. This program called CAST, Contrast for Auditory and Speech Training by Ertner, 2009. Comes in a pretty little box. I'm going to show you this little box in a minute. But it has discrimination, consonant discrimination by these features with picture cards already done for you. Has a little pretest, so you determine with a short little pretest where is this youngster. Can be used with children well up through middle school. Actually, it could be used with adults, but because it's kind of got pictures in it, some adults don't think that's as appealing. But the contrast, the word would be appropriate. Dazzle is the developmental approach to successive listening, and it too is a commercially available program, comes with a pretest and a graded series of lessons and many, many word lists at each of these varying levels. Sky High, which is one of the questions at the end of the chapter, is a very old program, originally developed in Utah, because Utah was such a sparsely populated state in our country that there were not speech-language pathologists, educational audiologists who could work with newly identified deaf children everywhere in the state. And so they had to develop some programs that were specific, that were structured, that could be used by other early intervention professionals or speech-language pathologists who had not necessarily been trained in early intervention. So there's a whole series. Sky High was adopted in the state of Tennessee more than 20 years ago. It's been revised. But it was used by the Tennessee Early Intervention Systems, actually even their predecessor, to enable early interventionists to work in homes with families, to work early interventionists in center-based programs to work with kids. Pollock's auditory verbal curriculum. Doreen Pollock was an educational audiologist from Colorado, was considered sort of the pioneer in the United States in terms of early intervention with children who had hearing loss. She was one of the grandmothers of the auditory verbal training programs, listening and spoken language. And she has a specific curriculum that ties both auditory skills and speech skills. So she was a big believer in this interweaving of auditory training and other components of oral rehabilitation, speech, language, listening. SPICE, and now we have SPICE 2, has just come out from the Central Institute for the Deaf, where your textbook author, Nancy Ty Murray, was a faculty member for many years. But SPICE is Speech Perception, Instructional Curriculum, and Evaluation. Comes in a wonderful little kit, those of you who like kits, with a pre-test and a post-test. Comes with all sorts of clever little props. So there are dolls and beds and ducks and horses and houses and cars and airplanes. So it literally is a self-contained kit with lots of object stimuli, then moving to picture stimuli. The auditory perception test for the hearing impaired is another assessment tool that again lets you assess, can my client discriminate long versus short, multisyllable versus single syllable, simple vowels, early consonants. So again, it's a way to assess what is the auditory skill level and use that to move into an appropriately designed curriculum. So here is SPICE, and see it has all these cute little things. And here is CAST, Here an example of a simple picture card looking at differences in sound. If I were an SOP, particularly in a school system, I certainly had these in my private practice. When I did a private practice, I invested in these. It simply made my life easier. I think they are highly regarded. CAST is David Ertmer, and Spth is from the Central Institute for the Deaf. They are well designed. There's evidence-based practice behind them, and it saves you lots and lots of time in developing these hierarchies and materials. So CAST is a form of analytic speech training. It's a progressive program moving from stimuli that are extremely different acoustically to later pairs where only one speech feature differs. There's a pre-test so that you can look at where does the youngster fit. Again, it does some auditory visual presentation initially, but then it very quickly presses you to move to auditory only, using the acoustic screen or hoop. A little later in this PowerPoint, and I put up as a attachment to the news announcement, auditory hoop instructions. How to make this acoustic screen that covers your mouth, but that lets the speech stimulus go directly to the client without impeding it. When you put a card up in front of your mouth, or you put your hand over your mouth, you are reducing the clarity of the acoustic signal. When you put the auditory hoop over your face, you give the individual good acoustic information because that screen is covered with acoustic cloth, just like your speakers. The APT, again, is an assessment that measures the ability to auditorily decode spoken language, and then you move into the appropriate level. The DAZZLE, again, is a hierarchy of listening skills, sound awareness in the beginning, but then speech perception, intensity, duration, pitch, and then auditory comprehension of actually words, consonants, vowels, words. Doreen Pollock has 10 levels for infants, beginning at sound awareness for infants, sound localization for infants, sound discrimination for infants, and it moves up. Doreen Pollock was the one who gave us the idea of listening age. She was the one who said to us, if a child has a significant hearing loss and receives some type of amplification, maybe a hearing aid before a cochlear implant, maybe they're going to get good benefit from the hearing aid, but some type of amplification, you start counting their birthday for their listening age from the day they became full-time users of amplification. So even if they're 2.5 and they were first implanted at 14 months, or if they're 3 and they became a full-time hearing aid user and got excellent benefit from their hearing aid at 6 months, you have to subtract from your expectations of their listening development those months of being unamplified or just beginning to be amplified or in this diagnostic process. So she's spent a long time promoting that idea among audiologists, and among SLPs. So we talk about a child's hearing aid birthday or cochlear implant birthday. So how old are they in listening months or years? And that should give us sort of an expectation of what kinds of auditory skills they should have. So Doreen Pollock was one of these folks who said, you begin at the beginning. If they have not heard sound, they have just received some type of amplification, then they are like a 1-month-old infant in terms of their ability to make sense out of sound. Now, an older child has cognitive skills and motor skills and visual skills that are appropriate to their chronological age, perhaps. So this idea of listening age is not they act like an infant. They don't act like an infant if they're 15 months and have just gotten a cochlear implant. But their listening age may be like an infant. So she was really big on that, and she would list objectives, and she would say their speech skills match their listening skills. So she would say the first level is you are just introducing them to sound, getting them to wear their amplification device, and then you move to auditory attention. Will they listen for a sound? Will they alert to a sound? And you should be working on vocalization. Then at the next level, they should be localizing a sound. You should be working on having them respond to sound, do something when they hear a sound, using a sound to control their behavior. You should be developing vocal play back and forth with a familiar partner. Then you should be looking at auditory discrimination. Can they hear the difference in ba, 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 ba? And you should be working on babbling skills. Then you should be working on more sounds, the development of first words, ba, ba, ma, ma. Then you should be developing auditory processing skills, actually deriving identification or meaning from those sounds and working on first words, action labels. Again, so she's saying what you expect in terms of speech and language goes along with what you see in listening comprehension. And so she developed this whole curriculum. Again, we've looked at Sky High, originally started as a home-based intervention program for infants and toddlers and preschoolers, used in many states as part of early intervention, the Tennessee Early Intervention System. Typically has 4 phases, again, with this idea that listening goes along with vocalizing speech and language. So this idea that we cannot expect a child with a significant hearing loss speech characteristics to be any more advanced than their listening characteristics. So we have to work on both at the same time. Spice, again, is a curriculum kit, absolutely self-contained kit that works on speech, listening, and processing. It has all sorts of the toys. It gives you a demonstration video. It can be used clearly with children, say, 2.5 to 3, up through about 12, and you can adapt it to slightly younger children and older children. But again, its auditory training categories are detection or awareness, this suprasegmental perception, then vowels and consonants, and then connected speech. So you can see that almost all of these programs that are designed primarily for children with hearing loss kind of follow this same Erber model of detection, discrimination, identification, and comprehension. There are a number of other commercially available materials for adults, and one of the ones that is been widely used is something called LACE, Listening and Auditory Communication Enhancement. It is an interactive, computer-based home training program. It's developed from Neurotone, so you want to just go www.neurotone.com and LACE will come up. It is an excellent choice for adults who either are relatively computer savvy themselves, can be independent and manage other kinds of online computer-based training like brain fitness or any of those kinds of things. It does focus on listening skills, discriminating sounds. It moves through processing, works on auditory memory, and it has built in some little tips about interactive communication strategies. Like any computer-based program, use of that with, for example, seniors depends on their computer skills, their financial resources. It's not expensive, but it is certainly an expense. And it's oftentimes an expense that Medicare will not pay for. So that is an issue. The person who can't maintain attention, who is looking at cognitive deficits, it's not a good choice for. The person who doesn't have good basic computer skills knows how to, it's simple, really simple. I mean, it's a single keystroke kind of thing. But if you can't turn on the computer or you get confused about how to get to a website, that's hard. It did originally come, and some people have the old disk-based or CD-based systems. I have seen it used very successfully in long-term care, where the facility might buy it and then residents, first with the help of an SOP or a CNA, begin to access it, and then someone is simply monitoring it. I put up in eLearn 2 articles attached to the news announcements for tonight, and one looks at simply the economics of computer-assisted instruction to give you a flavor of what people are talking about. It is an economical kind of intervention, particularly for adults who don't have time, can't take off work, for older adolescents, for college students who need extra practice, and again, are basically pretty independent and computer savvy. I also put up a 2013 systematic review of a number of these programs. And while it is true that most of the research suggests that auditory training is effective for most clients who persist in finishing the program, it's also true that most of these studies are not what we would call highest quality studies. But you all are now getting ready to graduate as speech-language pathologists, and you know that our research across the field of communication sciences and disorders is not always the most robust, the highest quality. So if we turn the lens on ourselves, we go, the results are generally positive, but the study designs for many of these efficacy studies leaves something to be desired. So there is certainly more research to be done across broader subject populations under conditions other than carefully controlled research-based studies. That issue of fidelity of implementation is a critical issue that we face as communication scientists across a lot of areas. The other program that we want to think about is this thing that Nancy Ty Murray has just published. It's called CLEAR. Literally, if you just go www.clear, you will locate it. She has developed a new online program where you can change the voice of the speaker. So the speaker can be an adult, can be a child, can be male or female. You can actually, through this system, record the speech stimuli that your client is going to be listening for in auditory training from a familiar partner. One of the things that we know is that individuals oftentimes can discriminate more easily the speech of someone who's familiar to them. So a spouse, for example, a coworker, a peer. And so this program allows you to really individualize the speaker's voice to your particular client. And the people that have used this just came out last fall. The people that I know that have used it have been very impressed with how motivating that part is for clients who have not been very good candidates for auditory training, just in terms of motivation. You can control the background noise level. You can control that with LACE too. So those are two of these online computer-based programs. Here are some others that are talked about in your text. The Baldy in your text is spelled B-A-L-D-Y. The iPad app is spelled B-A-L-D-I. And Baldy is a Yule Brynner, no hair guy that moves around, that you can use to do lip reading, you can do auditory training, you actually can do speech training, because in some of the versions you literally strip off the skin and you can actually watch the oral mechanism move, just like if you use Speech Tutor. Baldy has a female twin whose name is Baldette, and that is oftentimes used. The other thing that you want to think about is that when we do auditory training, just like when we do speech and language therapy, if our clients have amplification devices, we must check them daily. Now, we spent a lot of time talking about that last week, how to do the steps in checking a hearing aid. And again, I put up in eLearn as an attachment to the news announcements for last week, that Oticon protocol for how do you do a hearing aid check. I put up a little picture of a kit by the Educational Audiology Association called the Hearing Aid Checker Kit, so that you can order in a pretty little clear plastic Ziploc zip kind of pouch, a hearing aid stethoscope, a battery tester, a loop, so that you would be ready to go. And I also put up several handouts of the Ling 6 sounds. We talked about that last week as you listening to your client amplification device so that you could use your normal hearing to ascertain, is this device itself working? Can I use my good ears and I go, ooh, e, sh, and then the seventh sound is silence to make sure that your client recognizes no sound. But you are using that to determine, do I hear it clearly? But now, when you bring the client into therapy every time, you're going to do the lean six sounds with the device on your patient. Now you have a different question. Not, is the device working, or do I need to send it back to the audiologist or the hearing instrument specialist because there's something the matter with the device? You're asking, does my client hear and have access to those six sounds across the speech frequencies with the device on? That's an entirely different question, a really important question. Has my client's hearing deteriorated? Is there something the matter with the way my client is attending now? So you're going to use the six sound listening check as a functional check of your client's hearing across the speech banana, across the speech frequencies. And so you want to make sure that you're doing both things. You may want to recognize that before you start any kind of techniques or activities for auditory training across any of these four levels, again, the first thing is my client getting the benefit that the audiologist intended, that I'm presuming they are getting from this device? So I have to check it. I have to check it every time. And then I can work on attending to environmental sounds, or discriminating between sounds, or localizing the sound, and understanding the meaning of a sound. I put up here a whole bunch of resources. Many of these resources you all may want to use as part of your communication modalities project. The Alexander Graham Bell Association for the Deaf is the primary professional and parent association focused on hearing loss, hearing aids, listening and spoken language, auditory verbal training. The John Tracy Center in California is an old center for individuals with hearing loss. Listen Up is another one of those parent information websites that provides lots and lots of information. So you may want to take a look at these as you develop that section on communication modalities. So as we finish up, I want to make sure that we think again, what is our responsibility for working with students in a classroom setting? It's to make sure that the student gets what they need for success in the classroom. So a lot of our work is about modifications and accommodations in the classroom. It's to ensure that whatever the family chooses as their preferred means of communication, that we support. It's not about what you would do with your child. You as a parent make a choice for your own child. But just as we are respectful of other types of cultural and linguistic differences, we need to be respectful of parents' right to select the communication means that they think is best for their child. Is it oral speech? Is it a purely auditory verbal approach? Is it cued speech? Is it total communication? Is it one of the manually coded English systems? Is it ASL? That is a parent preference, and our job is to support the parents in that choice. Now, we provide information to parents about all of those modalities. And you can certainly offer an opinion, but we have to be ever so careful that ethically we're not overstepping our boundaries and deciding for a family and directly or indirectly coercing the family to choose the communication mode that we prefer. Our goal is to give parents information and let them make the choice and then support that choice. Whether or not it would be the choice you would make is really beside the point. So we need to be thinking about focusing on the effect of a hearing loss on a child's academic and social engagement. That's what IDA is about. We as related service providers are there to support a student in making the best optimum use of the academic and social environment in the school setting. We do have to pay a lot of attention to the severity of the hearing loss. We have to pay a lot of attention to whether the child is a good user of the communication technology that's out there. Is this child a consistent user of CIs or cochlear implants or a BAHA and FM systems? We often see children, unfortunately, who are fit with CIs, with cochlear implants, with BAHAs, who don't become consistent users of that amplification. So their accessibility, even though the audiologist may have chosen the most appropriate option for them, is not happening in reality. That is, and unfortunately, that is becoming more and more common. I had a recent discussion with the lead pediatric audiologist from the University of Tennessee at Knoxville, and Dr. Anne Marie Tharp, who is the graduate, who is the chair of the department at Vanderbilt, who is an international authority on pediatric audiology. And we were talking about the changes that have happened as we now implant children earlier. We buy very expensive hearing aid technologies for children. We fit children with BAHAs, and while many, many families have profited immeasurably from that access, we also see children who are implanted early where we have purchased highly expensive binaural hearing aids or BAHAs, and their families, for whatever reason, are not able to follow through. So they may have been implanted, but they come to school without the external processor. They come to school, oh, my hearing aid got lost. No, I don't know where it is, I lost it. So our job is always to look at this youngster in the context of what is the reality that is happening with that child, and to be realistic about what auditory training can do, but it's predicated on having appropriate amplification. And sometimes the first problem is getting the amplification that's been recommended and that is appropriate actually in place on a day-to-day basis. That may take social workers, it may take school counselors, it may take a lot of things. So we have to think about the service options. So before we design goals and objectives, we have to take a really careful look at functionally where this child is and what are the potential barriers that might occur. Again, I put up this auditory hoop. Instructions, literally, how to make you take an embroidery hoop and you literally put 2 layers of speaker cloth that is acoustically transparent, but visually you can't see through it. And you cover your mouth and nose. And you use that hoop to allow you to do auditory training activities. You can start with using the auditory hoop while you do the Ling 6 sound test. How much does this child get visually when I do auditory and visual together? When I use the hoop and cut the visual clues, I eliminate the visual clues, what happens? That should help you make realistic predictions about what can this youngster do in the auditory training, auditory only activities. So we use the hoop then as a way to practice. Listening and spoken language specialists, auditory verbal specialists, use the hoop a lot doing auditory training activities to really push the youngster, to push the adult. Listen, Mr. Jones, I want you now to listen. And we use this thing called the acoustic sandwich. We may look and listen until the client can be successful. Then we use the hoop, which cuts out the vision, and it's now auditory only, to see if with that additional practice, understanding what the task is, building some motivation, building some confidence, they can then listen very hard and be able to make that discrimination. And then we may, if they experience difficulty, we may remove the hoop and go back to auditory visual when they are struggling. So learning how to use the hoop to introduce difficulty in the auditory only condition, but knowing how to successfully use it is really important. Again, our job as SOPs is to put it all together, to look at auditory training as sort of a bottom-up approach, an analytic approach at its essence, using that linear progression from one level of difficulty to the next, recognizing that its audition is critical to speech training and language training, because visual clues aren't always going to be available in the environments that either our adults or our children work in. That children best learn language through hearing it in their environment. That presupposes that they have auditory access through devices, but that they also have had auditory training to use this sound that their devices provide them. And to recognize that audition is one of the real keys to learning in a school environment. And it's also the key to social interaction, relationships for our seniors. So again, auditory training is designed to help individuals maximize the use of the residual hearing that they possess. The goal is to develop the ability to recognize speech through the auditory channel as much as is possible and to interpret it correctly. So the first step is maximizing the residual hearing through amplification. And then thinking about children who are the main recipients of auditory training, but thinking about adults who get a new cochlear implant, who have a sudden hearing loss and have gotten amplification so that they are having to learn to listen again, or listen now with an impaired mechanism, or listen with a new device. The benefits clearly indicate that individuals do make gains. There is newer research coming out, particularly from the Northwestern Acoustic Research Lab, that suggests that we are actually seeing neurological changes that produce behavioral changes, that individuals can learn to distinguish two sounds that they previously couldn't with consistent auditory training. So that's encouraging to us that the brain, even older brains, even aging brains, can make neurological changes, and that auditory training can make a difference. That children who are in auditory oral education programs typically do better on speech recognition tests because they simply had so much auditory training practice. So the practice does help them use what they have. Again, you want to make sure that you are looking at the key resources. You want to make sure that you are paying attention to the fact that you want to work in the sweet spot. You want your auditory training activities not to be too hard and not to be too easy. So somewhere in this range of 50% correct to 80% correct is where you want to be targeting your efforts. You want to look at analytic training, and you want to look at this beginning of synthetic training. And I put some more resources up there for you to take a look at. Why don't we do this? Why don't we take a little break here? Definitely time for a break. I'll stay on here if any of you have questions, but go take about a 5-minute break. It's just a little bit before 8. We'll get back together about 8:05, and we'll whip through chapters 5 and 6 on speech reading. Everybody take a little break for a minute.
Dr. Fitz.
Mm-hmm.
This is Sarah Sewell.
Yes.
I'm looking everywhere
Hi.
for that study. Hey, I'm looking everywhere for that study guide and just cannot find it. Can you tell me again where it is?
Okay. The PowerPoint that we just talked about auditory training, or this one?
I believe you said there was a study guide for comps that you had put together.
I think it just says SPTH is a PDF. I think I uploaded it. Don't tell me that I didn't upload it. If I didn't, I will email it to you. But I think I attached it to the news announcement for tonight's class. Yeah, I'll tell you the other place that it is. It's in the content section.
Okay.
Open the content section. Open the first module. And see if you don't see it there.
Okay.
If you don't, let me know.
Okay. Okay, I will. I'm gonna try to find it.
Or I'll email it. Or I'll try the content. Or I'll email it.
Okay. If you don't hear from me, then I found it. If I don't find it, I'll let you know. All right. Thank you.
Mm-hmm. Okay, folks, it's time for us to sort of get back together and finish up this discussion of speech reading. While you are looking for the COMPS study guide, I want to point out that I'm looking right now in my class news that I did attach. And I want to point out that I did provide some PDFs of some PowerPoint handouts from the ASHA online audiology conferences. ASHA does a huge online training for audiologists every fall. And they focus on things that are sort of new ways of looking at auditory training and audiological issues. There is one by a woman named Linda Thibodeau. She actually is a PhD, SLP, and audiologist at the University of Texas at Dallas. And she runs an intensive auditory training program for individuals in the greater Dallas-Fort Worth area. And I want you just to take a look at that because it gives you some examples, and she talks about what do we do with adults who are new hearing aid users, new CI users. How do we design some training that will be helpful to them? And she talks about you can do this once a week, or you could do it once a month, or you can do it intensively for a week. But some of the things that she talks about are adaptable to be doing in a long-term care facility or a skilled nursing facility on a weekly basis. So you may want to look at that one. The one by Olson called Auditory Training with Adult CIs is a specific set of activities to do with auditory training with new adult CI users. And because several of you said your clients that you're thinking about working with are adult CI users, I thought you would be interested in looking at specific auditory training for older adults with CIs. The other one that I mentioned earlier tonight by Sanders on dual sensory impairments. Again, these are PDFs of the PowerPoint handouts from this online conference. Does a really nice review for those of you who have patients who have visual compromising conditions and sort of a little tutorial on visual impairments. So I wanted to call your attention to those options. Let's talk about speech reading. Nancy Ty Murray, for some reason, in this edition of the text, put speech reading into 2 chapters. She sort of talked about in chapter 5, what is speech reading, what are the characteristics of a good lip reader, speech reader, how do we use speech reading, what actually happens when we speech read, and then use chapter 6 to specifically talk about speech reading training, speech reading hierarchy. Actually, in the newest edition of this textbook that I did not choose to use, the 4th edition, she puts all this information into 1 chapter for adults and to another chapter for children. But let's talk about speech reading. I mean, we want to think about what is speech reading, what makes a good speech reader, talk about the limitations of speech reading. This idea of, oh, I heard about a person who was deaf and he could read anybody's lips. The FBI hired him because he could read lips across the room. Those actually are anecdotes. People don't become perfect lip readers because there is simply so much information that is not conveyed visually. And our eyes are able to process only so many movements per second. And in fact, normal running conversational speech has more lip movements than we are able to process. So we're not able to process all of the information that might be provided from lip reading. So we're going to look at some speech reading assessments, and then we're going to talk again about this idea of home-based, online, computer-assisted auditory training and speech reading options. But to try to make this a little more relevant for you, I want you to think about Mr. H. Mr. H is a fictional case study, actually much like you're going to have in the afternoon portion of your comprehensive exams. You're going to be given both a pediatric client and an adult client, and they are clients who have multiple issues, not just hearing loss, not just aphasia, not just Parkinson's, not just speech sounds. So multiple kinds of issues. But I want you to think about Mr. H. He's an 80-year-old male. He presents with a right hemisphere stroke. So right, not left. So start thinking about right hemisphere. He's currently a resident at Sunny Acres for rehabilitation services, and he's getting physical therapy, occupational therapy, and speech therapy. His cognitive and linguistic abilities were assessed using the RIPA, Information Processing Assessment Geriatric, because he is experiencing information processing issues. So think about Mr. H as we go through this, and think about how Mr. H might or might not benefit from specific therapeutic intervention in terms of speech reading. It is important that we make a distinction. Lip reading is a lay term that you often hear people use. He's a good lip reader. Lip reading requires the listener to recognize the different sounds of speech by observing movements of the lips, the tongue, the jaw, and facial expressions. So it is visual only information. Speech reading is the typical way people with hearing loss and normal listeners interact in their environment. Speech reading means that you're interpreting speech through facial expressions, gestures, body language, as well as auditory clues. So it's everything. It's auditory and visual. We also can look at just auditory discrimination or speech recognition testing, which is what the audiologist does in the sound field system, where they deprive the individual they're testing of any visual clues, either through a glass window that's clouded and an auditory hoop. The most recent generations of our digital hearing aids actually provide a very enhanced speech signal, while they use noise control strategies to cut out background noise. In noisy environments, in real life, however, the listener is going to depend both on auditory and visual signals to recognize speech. And oftentimes for our clients, that's what we need to keep impressing on them over and over. We need to encourage them to use auditory and visual signals to recognize the communication that's directed to them in everyday situations. We may do synthetic, analytic, individualized, formal training in auditory training and lip reading, speech reading training. But we need to help our clients recognize that in the real world, they need to be looking and listening, that that's one of the fundamental remediation techniques. So when we think about what goes on, we, from research, know that we all use the movements of a person's face and body to understand a speaker's thoughts. We look at head nods, we look at facial expressions, we look at informal gestures. All of that visual information is part of how we understand what our speaker is saying to us. Speech reading becomes a coping strategy that people with hearing loss use as they get less and less effective information from the auditory signal. That probably doesn't happen to many of you, but you have been in a noisy restaurant, or you've been in a very large amphitheater where you're at the back and it's kind of dark. You've been in a situation where there's a lot of background noise. And even you, with normal hearing, start watching the speaker's face. You focus your attention on those additional facial cues. You're actually using that visual information to supplement what you're not hearing. Well, obviously people with hearing loss who use hearing aids or cochlear implants or BAHAs hear quite a bit. And the better their technology and the more experienced they are with the technology and the better auditory training they've had, the better they use that auditory information. So they only use speech reading sort of as an extra, an accessory. One of the interesting things I always like to point out is that we all do speech read. In fact, if you look at very young infants, they make those pre-speech mouth movements and imitate other mouth movements in like tongue protrusion and lip pursing and mouth opening. Very young infants are already keyed in to focusing on the face, focusing on the mouth. So when we try to recognize speech using even the visual signal only, actually our auditory cortex becomes activated. Because as normal listeners, language is centered in, and speech sound recognition is centered in our auditory cortex. And when we're trying to recognize the visual information, we do process it in the visual cortex, but the auditory cortex is also activated, meaning we know from the very young infants and from our own adult experience that we combine audition and vision to actually extract meaning from the speech signal. So when we think about what makes a good lip reader, somebody's going to say, I bet it's somebody who's deaf. Actually, that's not true. Deaf individuals are no better speech readers than normal listeners in the aggregate. There certainly are individuals who are deaf who have practiced using speech reading to the maximum extent possible. But all of these factors, intelligence, educational achievement, presence or duration of the hearing loss, age at which hearing was lost, gender, SES, none of those reliably in research studies predict lip reading performance. There is some correlational evidence that visual word decoding, working memory, lexical identification speed, phonological processing, and verbal inferencing actually do predict modestly speech reading success. It's also true that young adults lip read better than elderly adults. Again, it's about processing speed. Older children perform better than younger children, particularly with the production of final consonants. And that's probably because they simply had more language experience. So they are skilled users of the language and can infer what would be the sound at the end of the word. Again, shorter latency of electrical neural transmission is characteristic of good lip readers. It's to this speed of processing that's the key. So what happens when somebody lip reads? They scan eyes, nose, and mouth and shift every now and then to the forehead or the cheeks of the chin, but they're really focused in that triangle of eyes, nose, and mouth. What makes lip reading hard is that some sounds are visible and some are not. That faster speech is harder to lip read than slower speech. That there's always the influence of co-articulation and stress effects. And so the same phoneme does not look the same in different words. Remember, we've talked about lip rounding, like in the word swim, S-W-I-M. That S, when I say the word swim, I'm already rounding my lips because the next phoneme is a lip-rounded W. But when I say see, that S is not lip-rounded. So, again, co-articulation makes a big difference. We're going to talk a lot, and it will be on your midterm for sure. Often is on the praxis. I can't guarantee whether it will be one of the questions that Dr. Smith chooses to put on your comps, but we're going to talk about visings and homophones. Those are the two terms that we need to think about. A vising is a group of speech sounds that appear identical on the lips. You and I typically think about those as phonemes that share place, and oftentimes manner. So we think about p, m, b. But when we get to the alveolars, it might be t, d, n. It also might include z, n. So it's not just the cognates. We're going to talk about homophones, and homophones are words that look identical on the lips. And in your chapter question, there was a discussion about homophones that don't seem like they look alike. Homophonous words are word pairs that look alike, even though the phonemes might be really different. So a word like ant and hand are homophones. They are homophonous words. Van and fat. You want to look on page 192 to make sure you are getting this difference. It's not just rhyming words, or it's not just minimal pair words. It are the phonemes in those two words produced in the same place of articulation. The other thing that influences lip reading difficulty is talker effects. Talker effects make some people very hard to lip read. Facial hair, lack of lip movement. There are a lot of things that make chewing gum, smoking cigarettes, a lot of things that make some people harder to read than others. But the basic issue is that 60% of our American English phonemes are not really visible on the lips and cannot be readily seen. That's many of the vowels and the consonant phonemes that are made interiorly. So while it's easy to lip read the labials, the labiodentals, the interdentals, it's much harder to read those sounds where there isn't actually a change in the lip movement. So bilabials, labiodentals, some of the alveolar sounds you can see. But in general, the consonants produced within the mouth have very limited visibility. There's obviously no difference visibly between voice and voiceless phonemes. So, h and b, t and d, k and g, s and z look exactly the same. And the vowels are mostly interior sounds. Now you do get some lip spreading with E, lip rounding with the back vowel, open mouth with the low back vowel like ah, but mostly they're interior. Conversationally, most talkers speak between 150 and 250 words per minute, about 4 to 7 syllables a second. That's about 15 phonemes on average per second. But your human eye can only register about 9 or 10 discrete mouth movements per second. So literally the limitation of our visual system says we simply can't process the rapid nature of conversational speech. So lip reading is hard. Co-articulation, we just talked about the effects of co-articulation. And we've talked about the fact that there are these visemes, those groups of speech sounds that are identical on the lips. And homophones are homophonous words that look identical on the mouth. So Again, talker effects confound lip reading efforts as well. So what happens when you speech read? When you speech read, you have to integrate what you hear and what you see, because you've got auditory information and visual information. And for years and years, there has been lots and lots of research about how does the human brain integrate auditory and visual information. Do we take those two signals and process them independently and then combine them, or do we process them interactively, both at the same time, to arrive at a whole? There is this effect, which will be on your midterm, I'm sure, likely on the praxis, and I don't know what Dr. Smith will decide about the comps, but this effect called the McGurk effect. It is the effect of auditory visual integration. We're on page 195 in your textbook. The McGurk effect was, again, originally discovered in an experiment by two psychologists. The McGurk effect is that perceptual phenomenon that demonstrates that we do use an interaction between hearing and vision in speech perception. It's really an illusion that occurs when you put the auditory component of one sound and the visual component of another sound. We put those two pieces of information together and we may perceive a third sound, not one of the ones that was presented auditorily or visually. So think about this word, these pairs, ba, da, ga. Those syllables differ by place of articulation. They are all stops. They're all voice stops. So the auditory information might sound like ba. If I show you a face, and the face is saying ga, no sound, but saying the ga, you perceive da. You perceive a third sound that's the middle way, it's the integration. And they do it over and over again with all sorts of stimuli, all sorts of talkers. So the results do suggest that when we recognize speech, we integrate auditory and visual speech information and we decode that signal. It's obligatory. It's the way our brains and the processing parts of our brain work. We can't make ourselves do something different, even though we know that there was never a da. It was ba and da. We still perceive the da. The other thing that we have studied a lot in the last 20 years or so is this idea of auditory visual information using this idea of neighborhoods. Again, it's on page 197 in your book. We talked a little bit about neighborhoods last week. Neighborhoods are lexical neighborhoods, or words that are in the same neighborhood. They're close to each other. Our brain sees them or thinks about them. So we've done, again, a lot of research that says when we try to put together auditory signals and visual signals and integrate them, we look for the words that belong to both neighborhoods. So here's a dense neighborhood right up here at the top of this slide. There are lots and lots of words. Auditory only, here's some words. visually only, here's some words, and if I put those two together, there are only 4 words that are both in the auditory neighborhood and in the visual neighborhood that overlap. And so if I'm trying to decipher what someone says, rather than having to choose from all of these auditory ones and all of these visual ones, I only, in my head, have to discriminate between these 4 words: force, fork, forward, and fort. And so it's easy, even in a dense neighborhood with lots of words, I at least have got a 1 out of 4 chance of getting it right. In a sparse neighborhood, not many words. Auditory only, visual only, put them together, and there's only 1 word that's in both neighborhoods, and that word is fish. So it makes a difference about how many words are in the neighborhoods. Is the visual lexical neighborhood, or groups of words that look alike on the face and have the same frequency of occurrence. Auditory neighborhoods are auditory lexical neighborhoods, or groups of words that sound alike and have the approximate frequency of occurrence. So what we're doing is we're integrating information. And we can predict, there are a lot of statistical models that help us predict what's easier and what's not as easy. But for most of us, when we're working with clients, including these 2 geriatric ladies who are knitting together, it's the talker, the message, the environment, and the skills of the speech reader, who is our client. So when we think about what can I influence, what can I change, I can certainly change the talker, meaning I can train my client's partner. I can certainly control the message. I can talk about how long, how syntactically complex, how frequent or familiar the words are, what is the context that I'm provided, or am I looking at words that are homophonous? So I can control the message and make it easier or harder. I can control the environment. What is the viewing angle? What's the distance from the speaker? What's the background noise? What are the acoustics in the room? What are other distractions? And I certainly can train this speech reader who is my client. I can practice with them. I can work on their speech reading skills. I can work on improving their listening skills. I can make sure that their amplification is appropriate. I can make sure that they're not fatigued or stressed. So I can influence these 4 aspects. So again, I can talk about, is this a familiar person? Is this person an easy person to speech read? That's one of the things that I'm so excited about Nancy Ty Murray's online program called CLEAR, that we can use familiar voices and familiar faces to work with our clients. We certainly can make the message easier or harder. We can change the environment and the situation. That's particularly critical in our long-term care facilities and in our school settings, that we have to make sure that our client has the best room conditions, that they're close to the talker, that they're looking at the talker with full face cues. There are some things that we can't control. We can't control their innate ability, their processing speed. We can't control their hearing acuity. We can choose times to work on speech reading skills when they are in good, less fatigued physical state and emotional state. So what do we do when speech reading is not enough? When we are working with clients who have the best auditory information that we can provide, the best speech reading information that we can provide, and we've done as much training as we can, and we're really sort of reaching that plateau. What do? We then start looking at other technologies that we might be able to use. We use oral interpreters. These are also known as oral transliterators. It's literally someone who sits with a clear view of the individual with the hearing loss and silently or softly repeats the talker's message as it is spoken, lagging behind by like 1 or 2 words. So it gives that person with the hearing loss who's struggling a little more information and a little slower information. That action of lagging a talker by a few words, mouthing or speaking the words, again, at a normal speaking rate with good enunciation, is certainly something that we see lots of deaf individuals beginning to ask for as an ADA accommodation. There is a national registry of registered interpreters for the deaf who are using various forms of manual communication, but they also offer a certificate of transliterating and an oral interpreter certificate. So that's something that we may want to let our clients know about. It absolutely is true that none of us are getting any younger, most of all me, but age-related hearing loss is the 3rd most prevalent chronic disability faced by older adults. And it is consistently ranked as one of the top 5 factors affecting overall quality of life for people over 65. So when we think about the majority, not all, but the majority of residents in our skilled nursing facilities and long-term care facilities, we are thinking about a population where we would predict a very high incidence of hearing loss, and that hearing loss itself limits the quality of life of our residents. So we need to think about how it is that we can help these older residents with some short-term speech, reading, and auditory training interventions. Not long-term, short-term, oftentimes in groups, because that influences or helps them gain motivation from others that are in the group. But before we do that, we have to do some measurement of hearing loss. We have to know what their hearing is. We have to know what sounds are hardest for them. And there are several tests that are in your book, the Iowa Consonant Confusion Test, the Children's Audio-Visual Enhancement Test, which we looked at last week, and the Iowa Sentence Test. We talked about some of these last time, that oftentimes these consonant confusion tests that have nonsense syllables, E, me, E, C, seem stressful for our clients. They give us, as SLPs, the best information about which phonemes are most difficult for you, but they lack that face validity. We looked at the Children's Auditory Visual Enhancement Test, the CAVIT, where we look at words that are highly visible on the mouth versus ones that are not as visible. And we looked briefly at the Iowa Sentence Test, where you take unrelated sentences with common vocabulary and ask the person to repeat that sentence back. A number of studies, not just this Timore-Safier study, conclude that older individuals do exhibit poor auditory visual performance, less visual enhancement than younger adults. They're less able to extract that visual speech information. And so they show this reduced ability to integrate auditory and visual clues to get to the correct phoneme identification. One of the things that we often use is a little test of lip reading called the Denver Scale Quick Test. It's 20 really simple sentences. You, as an SLP, administer it. It's a live voice test, and you score the sentence as correct if the person gets the gist of the idea. So it's not a verbatim repetition. You're looking, did you understand these familiar common sentences? And SLPs can use that as a, again, quick and dirty lip reading test, and you can do it as a lip reading test, a speech reading test, or an auditory only test. Another instrument that we oftentimes use that's in your textbook is the Hearing Handicapped Inventory for the Elderly. Again, it's designed to assess the handicap, the quality of life that a hearing loss produces. There's one for adults, there's one for the elderly. And it simply asks individuals to rate yes or no, or sometimes, is this a problem for you? Again, it's in your textbook, very appropriate for you as an SLP to use as a way to assess the hearing handicap. There's another one also in your text called the Communication Assessment Procedure for Seniors. Again, designed specifically for individuals in some sort of extended care facility. Again, let's us evaluate the attitude, the specific communication situations that are most problematic for the individual. Again, one of the things that we sometimes see when we work with these individuals in adults who are busy in work settings or seniors in long-term care or skilled nursing facilities, we oftentimes see that long-term therapy is simply not an option. Not an option because of cost factors, inconvenience factors, time factors. And so we are looking for online computer-assisted kinds of options. And this talking head, the Yul Brynner Baldy talking head, has oftentimes been used for speech reading practice as well as auditory training and speech training itself. Baldy can be used to teach children speech production and speech reading, and it has been used at the Tucker Maxson Oral School for the Deaf in Portland, but it's also used oftentimes as a home-based program. I'm going to So one of the things that, again, we do want to think about is we've got a lot of options out there. Your textbook talks specifically about looking in Chapter 6 at these hierarchies for developing speech reading skills, in the same way that we looked at the hierarchies for developing auditory training. And if you'll look at thinking about those hierarchies, you're, again, always looking at what are homophonous words. If you look on page 227, you'll see these speech reading hierarchies and some examples of consonant analytic speech reading training. And then you'll see some examples in the next couple of chapters of synthetic speech reading activities. How do you work, for example, in a group about a thematic topic like cooking? Or how do you work with children in a play, language, speech, auditory training, speech reading activity? The other thing that you do want to pay attention to is on page 224, there's simply a one-page handout. It's sort of the handout for speech reading. And it's just a reminder list of techniques and things that we want to encourage our clients who are having trouble in conversational settings, having trouble even with their hearing aids. How can you improve your speech reading in an indirect way? We oftentimes use that in a group setting, so we may do a few, very few, short-term group speech reading sessions, and we talk about watching the talker's lips, providing information to the talker about how to communicate with you, the person with a hearing loss. So you tell the talker, don't over-exaggerate. Speak clearly, but don't over-articulate. Make sure that the room is well lit, and I'm going to try to move to an area where the light is on your face, not shining in my eyes. Minimize background noise. Tell me the topic that we're talking about. It helps me if you say, let's talk about going shopping, or let's talk about cooking with Julia Childs. Whatever it is, if the person has context, then they can begin to activate not only what they know about that topic, but they're primed for certain vocabulary. Pay attention to context clues, and then keep a positive attitude. Oftentimes our clients do get very discouraged. They find it challenging and difficult, and so we do have to work with them to keep them motivated. That's why making sure that the activities that we plan for our clients are easy enough that they can get some success. Because if it's too hard, they then do get very discouraged. The data on speech reading, just like the data on auditory training, basically says that we can make some incremental difference with training, but that there are some individuals who are simply better lip readers than others. So when we talk about training, we need to oftentimes talk to our clients about what is the one situation or what are the two situations that are most problematic for you. So that if a person talks about using the phone, talking to my grandchildren, when my wife comes to visit, when I am in Dr. Jones' class, whatever the situation that your particular client nominates as a challenging situation, those are the ones to work on, rather than trying to say, we're going to be able to systematically improve your overall speech reading ability or your overall auditory training. So oftentimes we have to say, what are the situations that are most difficult, and can we take a multi-pronged approach to that? How can we enhance your speech reading? How can we help you with particular sounds or phonemes that are hard for you? How can we maximize your use of amplification and assistive technologies? So again, thinking about ways to take a multi-pronged approach rather than thinking we can, with intensive, long-duration therapy, make big gains. We might go for something less ambitious for our clients, and also something that we can do. SOPs in schools with children typically do not teach speech reading. They teach speech reading in the context of language therapy, in the context of training specific speech sounds. And we call children's attention to those speech phonemes that do have a good visual cue. So we work with and the F and V phonemes, and we do call attention to the visual component. But we do, again, speech reading mostly in the context of support for listening training and support for speech production rather than separate speech reading. Every now and then you will find a client, an adult client, an older adolescent client who wants to work on speech reading. And there are a number of materials on the market. One that I like is called, I'm going to write it in here, Clues, which is speech reading for adults, and it's a pro-ed publication. And it literally is a very systematic approach where we teach the homophonous sounds together. So we teach pa, ba, ma, and v, all the bilabials and labiodentals. And then we teach, for example, the alveolars, ta, da, na. And we work with the sound in isolation, full face, the sound in isolation at a 45-degree angle, then sounds and words, full face, and in angles, 45-degree angles, words in similar word pairs, words where they are related in terms of a subject, common phrases, and then do short stories with some clue words. Short stories with questions, and then some sort of situational activity. So a whole series of lessons. And I have on occasion used this kind of manual. It's nothing magic, but it does provide some picture stimuli. It provides all of the stimulus words. It gives you the little phrases and sentences and stories that relate to speech reading of these individual phonemes. And again, I have sometimes used that. I usually don't suggest that. I don't start with that. But if I have a client who says, I really just need to learn to speech read, and I'm having trouble with this, and I want to work on it, then I do take my patient's request and what they want to do, and I try to go from there. So that's a resource that you may want to be familiar with. It's a fairly old publication, but I think it's still available from ProEd, or it's in one of their libraries. We have a couple of those copies here at TSU, and we do, on occasion, use it. It is time for us to go. I know you all have other things to do. Did you find the COMPS study guide?
I did not.
Tell me.
I did not.
All right. Let me get out of here, and I will send it to everybody. I'll just send a group email in eLearn and put it as an attachment. Everybody okay with that? That'll be what you need to do for the remainder of the class. One, you need to make sure you've submitted. There were a few of you who hadn't done your study questions. You need to do that. You can use this extra time to look at Bobby and Drew, which is your discussion for this next week. Just look at those two little case studies at the end of Chapter 4 and pick which youngster of those CI users is most interesting to you, and comment, discuss what challenges they presented and what you thought of their treatment plans. Next week, we are moving on to a new unit. We are moving on to the section in your textbook about communication fluency, conversational fluency, communication strategies, and we're going to do chapters 7 and 8. Actually, this section, I believe, is the most important section in this course, because I think that oftentimes it is looking at conversation and communication strategies where we will make the most impact for both our adult clients and our children, thinking about how do we help them repair the breakdowns that will occur, rather than hoping that they will never have a communication problem. We need to think and teach them what are communication breakdowns. When do they occur? Why do they occur? How can I repair those conversational breakdowns? How can I develop a communication style that enables my listeners and the people I interact with to help me in the process? So we're going to look at conversational styles, conversational behaviors. This is where we think about AR as an ecological interactive process, that our client may be the person with the hearing loss, but we are going to be intervening with the partners that are part of that client's environment. And we're going to be teaching that client strategies or tactics to control their environmental situation and make the best of what is sometimes a really challenging and difficult situation, but to learn how to approach that with a problem-solving attitude. So I actually do think that this is important. Yes, Sarah, that's one of the most important things for us to remember. I'm glad you brought that up. Speech through a cochlear implant is electrical stimulation. It is an electric signal. It is not an acoustic or auditory signal. So it doesn't sound anything like speech. Now, people with hearing loss learn to take that information and code it in their brains and derive meaningful sound information, but it is not speech. That's why so many people who use cochlear implants are beginning to opt for bimodal stimulation rather than 2 cochlear implants. They want a cochlear implant that does enable stimulation of some of particularly those high frequency parts of the speech banana where they don't have any neural stimulation. So that is important. But they want low frequency and mid frequency auditory information through a hearing aid, so that they sort of get the both of those kinds of things. It is robotic, and you hear this over and over again from our clients. It sounds robotic. Music doesn't sound anything like I remember it. And the people who make the worst CI users are musicians. There's a whole new segment of audiologists. In fact, I just read something on one of my audiology blogs today about music therapy and about trying to satisfy patients who have a hearing loss or are losing their hearing and are not pleased with the robotic information they get from a CI. And it is sad. Our answer may be, at least partially, to talk to these folks about, rather than always the second CI, is to talk about using a hearing aid in one ear and a CI in the other. That's what we call bimodal. The other thing that we're seeing, very fortunately, is that there are lots of improvements in CIs. We are getting now to develop, well, it's really third generation CIs, where the insertion of the electrode ray in the cochlea is not as deep, and so there is more of the auditory low frequency information preserved rather than most of our CIs now. Certainly our older generations of CIs, literally when the electrode array was inserted into the cochlea, you destroy the auditory stimulation, and it becomes all electric. So we're seeing improvement in the technology with shorter electrode arrays, and we're seeing more and more that audiologists are now, in a way, listening better. Surgeons are listening better to our patients, and they're telling us they don't like the sound very much. And again, it tends to be musicians or people who, really enjoyed music, who say, this isn't cutting it. I can decode the electrical stimulation. It does help me understand speech that I can't without the CI, but it's not the same. So I think it's important for us as SLPs to understand that, to be empathetic with our patients, to talk with them and have them talk with their audiologists and their surgeons about, what are some of the answers, what might work, and to recognize that this appreciation of music is maybe for some individuals a really critical part of their quality of life, and to be thinking about solutions that are driven by quality of life issues, not simply, what can we implant surgically, what can we fit. So I think that is a really important aspect. I will say good night to everyone. I will go email everyone the study guide for the comps and the study guide for the midterm exam. And we'll go over the midterm exam next week. Good night, everyone. Have a good rest of your week.